Welcome, everyone. My name is Philip Reiner, and I am the Chief Executive Officer of the Institute for Security and Technology. We want to say thank you to everybody for joining us here today. Thank you to CyberScoop for working with us to host this discussion as part of their Cyber Week. And obviously, this conversation happens in the midst of what is Cyber Awareness Month. All joking aside, I think it is an incredibly important thing to remember that as we have this conversation here today, that this is not really a one-off set of issues. This is a persistent challenge that the healthcare industry faces. It's something that has been going on for years. A number of the really fantastic panelists that are here with us today have been grappling with it firsthand. And while we do this in the middle of Cyber Awareness Month, I think it's critically important that we keep these issues at the forefront of our thinking. I want to say thank you to everybody for that's here to listen into the conversation, but please do engage with the panelists as the conversation goes forward. Get your Q&A in there. They will have time at the end to listen and respond to those questions. The one thing that I was going to say was, looking back to about a year ago to kick things off, was as we were looking at really a wave of ransomware attacks that were hitting the healthcare industry, and thinking about what we could do about it, and putting together the ransomware task force that then put out the report earlier this year, that it was just so incredibly infuriating to see this happening to the healthcare industry, and knowing that it's a part of our critical infrastructure, and yet seeing it continue to just hammer the industry, and it really has not let up. I think despite all of the activity that we see out there that's happening with the administration and internationally, companies and everybody pitching in, trying to do more, it's really astounding just how much of a threat that this poses to the healthcare industry. And so really want to say again, thank you to all of you for being here today, but thank you to the panelists, to Jessica for hosting, but to Lisa, Stephanie, and Christian for being here to talk a little bit more about the threat and talk a little bit more about what else can be done about this. So thank you to everybody, and welcome to the conversation.
Well, great. I think that's my cue to go ahead and kick us off. So like Philip said, thanks everyone so much for being here. I am incredibly excited about this particular group. I've had the privilege of being on panels with them before, and I know we're going to have a good conversation. So I'm going to go ahead and introduce myself, then turn it over to the panelists to introduce themselves, and then we will get into the meat of the conversation. So for those of you who don't know, my name is Jessica Wilkerson, and I work for the Food and Drug Administration as a senior cyber policy advisor. So to put it as bluntly as possible, I do medical device cybersecurity all day, every day. I also do more work with the broader healthcare sector, including working with HHS and with CISA, but at FDA, I do medical device cybersecurity, vulnerability response, and so on, as well as trying to develop policy that helps put us in a better position tomorrow to deal with cybersecurity in the medical device sector. So why don't we do this? Why don't we start with Christian, and then go to Stephanie, and then go Lisa for introductions.
Well, thank you so much, Jessica. My name is Dr. Christian DeMaff. I'm an emergency medicine physician and an assistant professor in biomedical informatics and computer science here at UC San Diego. My operational role is as the medical director of cybersecurity, where I kind of help bridge the side between the technical and the clinical workflow in securing our enterprise. Have been very excited to be involved in this panel. I'm looking forward to the discussion.
Perfect. I'm Stephanie Domas. It's great to meet everyone. I am actually coming wearing two hats today. So I first met Christian and Jessica because I spent a large portion of my career specifically focused on medical device cybersecurity. So my background is in the bits and bytes of how you actually secure embedded systems. So I spent a number of years working as a consultant with a lot of medical device manufacturers, helping them do security correctly. About 6 months ago, I switched gears and I now work at Intel, and now I'm focused on the role that hardware-based security can play in enabling security inside of systems. And so two very different perspectives, but both at the end of the day are how do you design and enable security inside of systems.
That's awesome. Nice to meet everybody and see everybody here again. It'll be nice when we can see you in person. So I'm Lisa Young, and I work for the Cybersecurity and Infrastructure Security Agency, so CISA for short. Some of you may not have heard of CISA. We are recently elevated to an agency within the U.S. Department of Homeland Security. And much like how FEMA falls under DHS, CISA is the nation's risk advisor for the United States of America. And I know several of our leaders have spoken this week at Cyber Week, but I'm what's called a CARES Act hire. And CARES Act was the Coronavirus Aid, Relief, and Economic Security signed in 2020, which brought a group of multidisciplinary people from different walks of life and different fields to work on a COVID task force at CISA. And last year, I'm filling in for Josh Corman. So for those of you who know Josh, great, say hi. He's on vacation, which we all said he needed to go on vacation, but he asked me to fill in for him. When Josh called me last year, when he was forming the task force, and he said, I'm putting a band together to do these things to protect the vaccine supply chain, I said yes. Like I didn't even know what the job was about or what we were going to do exactly, but I said yes. And so I took a sabbatical. I went to my boss at Axio and I said, look, I really want to do this, and this is really good for our country. He said, absolutely. So I took a sabbatical from my role at Axio to work for Josh and the task force. And it's been a wild and exciting ride. Our major effort when we started the task force was to protect the vaccine supply chain. Actually, the biggest, many of you are familiar with the biggest names in vaccine production, but what we were looking for is some of the small, what we call ball bearings, some of the really important things that could be disrupted from a supply chain or cyber attack. And some of you may have seen our director, Jen Easterly, or some of our other leadership, on social media asking people to come and join the CISA mission. And please do consider it. It is an enriching experience. But thank you so much for inviting me to be here. Let me just say that my mantra is cybersecurity is a team sport, and all the opinions expressed in this discussion are my own and not reflective of any of my employers. And I will put my social media in the chat, which I hope the rest of you will, so we can continue the discussion. So Jessica, I'll give it back to you.
Perfect. Thank you. So I think what we wanted to do first, we've got a little outline that we as panelists came up with together. But the first thing that we thought was important to start with is, cybersecurity and healthcare cybersecurity has certainly been making the news lately. This is something that I think most people are becoming at least a little bit familiar with, even if you don't work in cybersecurity like we do every day. So we thought one of the places that we should start is really trying to set this scene of we're talking about ransomware. We're talking about ransomware specifically against hospitals and healthcare. What does that actually look like, especially for folks who are on the ground dealing with this? So we are very lucky in that we have Christian here, who, as he said, is a doctor of emergency medicine. And Christian actually testified in front of Congress earlier this year on these exact issues. So Christian, I'm hoping you can get us started off with one, giving us a doctor's perspective on this topic area, but also talking a little bit about what you did with your testimony and some of the issues and the concerns that you had raised with that.
Well, thank you so much, Jessica. I really appreciate that. And I wanted to just, again, like you mentioned, set the stage. And I can talk a little bit from a personal perspective, but then also from some of the anecdotes that have happened with recent healthcare ransomware attacks. And what we'll start off with is that the reality is that modern healthcare is entirely dependent or nearly entirely dependent on digitized workflows that are technology dependent and vulnerable to ransomware attacks. And so imagine showing up to your job and all the tools that you use to do your job are no longer functioning. And the solution of which is to go back to an antiquated way of doing your job without ever having done it before, or maybe only having to do it for a couple hours once every few years. And then imagine that your job is taking care of people, and if you don't do your job right, people die. It is no understatement that the electronic health record, connected medical devices, and other types of technical and digital workflows support time-sensitive, critical patient care flows. So what am I talking about? Patients who are having strokes, patients who are having heart attacks, patients who are having severe infections like sepsis. They don't stop having those conditions just because the hospital is under ransomware attack, and they still have to get care. And in order to adequately care for them, you need all those systems to be working and functioning at a very high level, because in some conditions like stroke, minutes matter. In some conditions like heart attacks, seconds can matter almost with out-of-hospital cardiac arrest. So it's the situation now is that we're all dependent on it. We're only becoming increasingly dependent on it. So as time marches forward, any analog systems or systems not vulnerable to ransomware attacks, they're going out the window. We're continuing to push medicine into a hyper-connected, hyper-digitized state. And then the physicians that are used to taking care of patients, and the nurses as well, and the rest of the healthcare team that is used to taking care of patients without those digital systems, well, they're retiring, or they're not flexing those manual paper workflow records, paper record workflows. And so their skills are atrophying. And what does that mean? It means doctors like me have never used paper records, which I would use in a ransomware attack, for example. And then if you've seen me speak before, I always joke, until 6 months into my fellowship, I had never handwritten a prescription. I always relied on the electronic health record to send an electronic prescription to a pharmacy. Okay, so we're really dependent on it. People's lives are dependent on these systems. And so what happens when a ransomware attack hits? Yeah, it's kind of clear. Those systems don't work. But what would that mean in practicality? And these are some of the anecdotes that are coming out from ransomware attacks in hospitals. Patients who might be having strokes, they need to get CT scans very quickly. And so there's reports of patients going to CT scanners and the workstations that are connected to them don't function. They've been ransomed. Or that the systems that will collect those digital images and send them to the radiologists for review and read to see if a patient has a stroke or not, they don't function. And so anecdotes of radiologists having to come down to the scanners, read images that are very sensitive to light and screens, for example, having to read those on workstations that are suboptimal for that, right next to the scanners, to then have to type out those reports or handwrite them and pin them to patients' gowns so that they can travel with the patients. These are the types of things that we are hearing have resulted from ransomware attacks at the institutions at which they are affected. It is also becoming increasingly reported now that hospitals will go on diversion. So they will say, we are so impacted by this ransomware attack, we can no longer see ambulances. We're going to have to send those ambulances to other hospitals. And what does that mean? It means that ransomware attacks have regional impacts and spillover effects at other institutions. And I can report personally that I worked at a hospital adjacent to one under cyber attack. And what did I see? I saw my waiting room times skyrocket. I saw ambulances, the volume triple what I would normally see coming to me, and seeing complex, very sick medical patients without medical records at my institution, affecting our workflow and the care of patients, even though we weren't hit. And so to paint this picture a little bit more broadly, we are very reliant on these systems. When they don't function, care can be impacted. And it's not just at the individual institutions at which are ransomed or hospitals are ransomed. It can now have regional effects, of which we are now more and more understanding. And I'm hoping that the impacts of those will become of public record and studied very similarly to that of other diseases and conditions. We need to start talking about how cyber attacks impact patients' lives and care quality and care safety, not just their data. And so that was the basis of my testimony in front of Congress, in which I called for us to start studying these things rigorously, for us to fund that research at a national level, and for us to understand that we're all in this cyber healthcare boat together, if you will, and that there should be no competitive advantage to healthcare cybersecurity at a hospital. Instead, we should be sharing resources. The federal government should be giving resources to hospitals that don't have the resources themselves to secure their systems in an effort to raise the cybersecurity bar across the entire sector. And so that was my plea to Congress. And again, one I feel strong to talk about in any questions and answers moving forward. And again, thank you for the introduction. Any other questions, Jessica, specifically about that?
No, I think you're good. I think we'll get into it a little bit later. So I was actually going to go to Stephanie, because like Stephanie said earlier, she spent a lot of time in the trenches that I'm now in medical device cybersecurity. So Stephanie, if you can talk a little bit specifically about how medical device cybersecurity fits into all this, and then feel free to add any other context or color you well please.
For sure. Yeah. And so there's a couple threads from what Christian said that I want to pull on a little bit from kind of that medical device view and the technical perspective. And so Christian talked about the kind of spillover regional effect of ransomware, and he was specifically talking about how there's this ripple effect with regards to, patients. But I also want to hit on kind of the networking piece of that. Ransomware doesn't stop at physical boundaries, right? So when you think of hospital systems and how, like, our local regional hospital system, I think has 100 something locations. On the back end, what that really means is their networks are all tied together. So the ability for ransomware and these medical devices to be able to talk to actually medical devices in a different physical facility, right? It could be halfway across the state. That is a very real network setup, right? Just because these things are physically separated, digitally, they're not. So when you think of medical devices, you think of, a lot of people immediately think of things that are maybe out of date, legacy, and they're not wrong. There's a lot of old legacy medical devices that are out there that are still performing their clinical function, but these get this reputation for, not having the best security. And so what you hear a lot of people really fixate on is, okay, well, isolate them on the network, right? If this medical device is posing a risk to that hospital's network, isolate it. That sounds really great at a surface level, but anyone who has ever worked in networking will tell you that is so hard to do. The medical devices are on the network because they need to talk to other things on the network, right? Medical devices are frequently feeding directly into EHR systems. So guess what that means? There is a digital pathway between that insecure medical device and the electronic health record servers, because there has to be. Otherwise, the medical device can't share its data. And so you get to these sort of tricky situations where you have insecure devices. Common security practices would be, well, isolate them or put them on their own network, but they can't be because they need to talk to other things on the network, because it wouldn't be on the network in the first place. And so you get this real complicated bundle of conflicting priorities. And especially as you start to think about how all these hospital systems, even physically separated, are actually digitally connected, it becomes so complicated. And I didn't throw out any solutions there other than to just throw out kind of the complexity of the problem. And so you also get into the situation where these medical devices, some of the hospitals that I used to work with, medical devices represented about 15 to 20% of the endpoints on their network. That is an immense amount of systems on their network that fall outside of their normal IT and security processes. And for most hospitals, that was the case. Their normal processes for updating and antivirus and patching only went to their traditional endpoint systems and did not include the medical devices on their systems. So that's a lot of endpoints that are in the circle of trust, right? They're in some of these main networks. They're not being maintained in accordance with your core security policies, and they have access to everything. So there's the stage for everyone of why it's so complex and really difficult.
Yes. Yeah. Thank you for doing that very well and frightening us all, I'm sure. So Lisa, you want to take us over next?
I will. And I will say, I know we're going to touch on this, but you also bring up a great point in not just, is it very complex and it's very hard to do, but also I have some stuff later when we get to some of the ways in which we might be able to fix this. Is there's also a resource constraint, right? I mean, when you think of cyber security having to be evaluated, all those risks having to be evaluated, and the complexity in conjunction with all the other complexity that normally goes on in medicine, it's amazing to me, and it's scary too. So I'm going to talk a little bit about. I have some. We've been following. To Christian's point about deaths from, not just COVID, but excess deaths from hospitals being overwhelmed, and then the complexity of sort of the intersection of medicine and whatever. In October last year, we were seeing the strain on the healthcare and hospital systems around the country, commodity shortages, workforce shortages, capacity shortages. Under normal circumstances, an increase in demand is usually met with a surge of workers or a surge of mutual aid or something like that. But what we're witnessing last year, we saw a hospital system that was ransomed, and it was quite a large system. And first, the reason why we've been paying close attention to this particular case is because the effects of the attack were long. right? So that gave us some ability to study it from the inception and over a long period of time. So if it's okay, I'm just going to go through this, and I hate to read this, but I'm sorry, I'm staying to script. So the insights that we gain from that might help with our discussion today, but the fact that the attack occurred in a widespread health crisis gave us some perspectives on things we would normally not see. But the ransomware attack immediately resulted in inaccessible patient schedules and records, disrupted communications, and delays in processing and communicating test results. But the downstream effects were canceled or delayed surgeries and cancer treatments, closure of several COVID-19 test collection sites, inability to submit radiology imaging, and loss of communication between hospitals and the network. And in this particular case, for the first week of the attack, the staff were required to log patient information, medications, treatment, clinical orders, and any position for which this was not possible was reassigned or furloughed for the duration of the downtime. And as we continued to examine the ransomware attack, a temporal element became sort of rise to the surface. The attack impaired system function in both the short term and the long term, meaning more than 2 months. So immediately after the event occurred, the entire IT infrastructure and network was down, including the medical devices. After a week, available offline backups of the system were accessible, restoring access to some functions. But over the next 2 weeks, network functionality started to return more rapidly. But even after more than a month, some network devices remained offline for cleaning or repair, but most of the hardware had been restored. 6 months after the attack, all hardware had access restored, but some tools remained out of service. And this becomes important when we think about how specific services were disrupted. In the short term, the cyber attack disrupted the ability for the systems to access the EHRs, the electronic health records, and the network-based services, such as cardiac and oncology. And this reduced capacity in the short term, potentially requiring diversion of critical patients, diversion of ambulances, which then sort of, spread in a ripple effect. In critical care, where minutes or hours can determine, which we heard, from heart attack or a stroke, diversions can drastically reduce survivability and recovery of the patient. So in the long term, access to the health records might remain limited, which complicates care for long-term patients that have detailed records. I mean, think about if you're undergoing, a long-term treatment plan. But also when you're doing sort of manual inputs, it reduces the number of patients and beds that a staff can actually can attend to, and potentially lead to worsened outcomes. In the weeks or months after an attack, hospital systems may still have to delay diagnostics and long-term care services due to data loss, if data loss was part of the ransomware attack. So I'll stop there and say back to Jessica, but I think we've heard sort of not just the scary stories of what could happen and what we've seen anecdotally, but the real sort of, from this to Christian's point, and I'm happy to hear you say this, we've actually done and have some things pending in medical journals about excess deaths from these types of conditions. So I'll stop there and say back to Jessica.
No, thank you. That's helpful context, because like I was saying at the beginning, and I think like we've seen in so many ways, cybersecurity can almost seem very abstract, or it's so technical that it's hard to get your head around. And so I think putting these concrete impacts, especially when it comes to patient care, because I could need patient care tomorrow. Our friends and family could need patient care. And with the widespread cyber attacks and cyber vulnerabilities that we're seeing, there's now this risk of, well, whose hospital is going to be next? Is it going to be the one in my neighborhood? So I think it's helpful. So the next thing we wanted to really talk about or start to dig into is we've now sort of set this stage of hospitals are vulnerable and we're seeing these impacts, but why? And Stephanie, I might go back to you to start us off, because you had really started talking about this with the device issues and the interconnectivity issues. So if there's anything else that you want to add there, or maybe dig in from your experience as to how did we get to this hyper-connected stage? How have we gotten to this point where, we do have legacy devices, or we have this issue where devices aren't receiving updates like their more traditional IT counterparts?
Mhm. Yeah, and so like my previous answer, it's all so complicated. But some of the pieces of it revolve around the immensely diverse ecosystem of like manufacturers that you have. There's probably some other industries, and none are probably in my head, where you have networks that are so diverse in the number of manufacturers that are all present in the network at the same time. You think of traditional businesses, they're pretty tightly controlling the amount of uniqueness on their systems, right? They've got printers, they've got door locks and computers, right? But you start to go into medical devices, you have thousands of manufacturers all sitting on those medical device networks, trying to coexist with each other. And as I mentioned before, having a need to be able to talk to things like backend servers. A lot of medical devices now use cloud backends. So also long gone are the days where you could put rules on that network to say, well, nothing can leave this network, right? It can only stay inside the hospital. A lot of medical devices use cloud-based backends. So guess what? You can't have rules like that anymore. So it all just becomes so immensely complicated. And then I mentioned before, the legacy issue of having medical devices that are 10, 15, 20 years old, still sitting on your network. The truth is medical devices go through so much immense testing that they're designed really well, actually. So they last a really long time, which is great from a capitalization and a purchase perspective, that these things are still performing their clinical function reliably. But cybersecurity is such a moving target and such a moving industry that honestly, it's near impossible to keep something secure that long without literally just shutting all the doors, right? Turn off the network and say it's not going to have a network anymore. But that immense number, I kind of circling back, of the immense number of manufacturers is one of the things that adds so much complexity to the system, because every single one of them has different update servers. They have different update mechanisms. They have different mechanisms for threat intelligence. So how they notify you about whether or not there's an update or whether or not there's a known threat, it's literally different for every single manufacturer. The update cadence is different for them. How the updates are applied, is it a physical thumb drive? Does you get a prompt on the machine? It's all different because there's thousands of those unique manufacturers. And so that just adds so much complexity to the system that even, when I'm working with hospitals in my past life and trying to help them put processes in place for how do you handle this, the process is like 60 pages long because there's so many special snowflakes in the room that there's really not an efficient way to handle all of this. So, if anyone on here is a health technology manager at HTM, kudos to you, because you it's hard. It is so hard to maintain these medical devices because they're so unique and they're so complex.
Yeah, and I know that in one of the groups that I work with, we had this issue, and it blew my mind. We had a chief information security officer who essentially was like, every time I want to do an update or figure out if I need to do updates for a medical device, I have to check 300 different websites. Mm-hmm. And so it is so much. Christian, do you want to pick up and talk about this a little bit from your perspective of why, from what you see, are hospitals particularly vulnerable, or are they particularly vulnerable in your point of view to other industries or other sectors?
Absolutely. I think there's been a couple of interesting regulatory pressures that have pushed us in this hyper-connected, vulnerable state. And then there's something inherent about healthcare itself. We'll start with the first. The HITECH Act, really infusing lots of money and incentives and then eventually disincentives for unifying electronic health records and the development of that and implementation of that. So that is such an important part of healthcare. It cannot be overstated that the electronic health record is truly the operating system of healthcare, in my opinion, and that you can't do very many things in healthcare without interfacing with the electronic health record. As healthcare was pushed away from paper records onto the electronic health record, it became very clear that they needed to have that resource, that software available to all the clinics at the same time, all the different physical locations within a healthcare enterprise, as well as have high availability in the actual hospitals themselves. So that pressure to do something fantastic, which was get us off bad, antiquated paper records, pushed us to then connect all of this infrastructure together, of which, Stephanie's done a great job of mentioning how hard it is for us to defend against those particular networks. And the other thing is that healthcare is, by its nature, quite collaborative and requires that at any given time, thousands, or hundreds or thousands of employees need to access those systems almost immediately, right? So when a cardiac arrest comes into the emergency department, in order for me to order the medicines and the tests and things to help that patient, I need to have access to that and the entirety of the patient record. And so that would not be tolerated at many other industries, that kind of access issue, if you will, because at a bank, you're not going to have a teller have access to the entirety of the records, for example, without some controls you can put in place. Because healthcare is very collaborative and has a high demand for high levels of access among a huge swath of your workforce, that's a particular complication. On top of that, I would say that there are a lot of competing demands upon healthcare. And again, as mentioned with Lisa, the COVID pandemic has been a huge stress test to the healthcare infrastructure, regardless of, irrespective of ransomware. And what we recognized was that there just isn't a lot of flexibility and capacity and the ability to handle surge very well in many places in this country. And why is that the case? It's because these things are very expensive, and redundancy and depth of ability to respond to that surge is so costly. And that in the status quo, many hospitals just don't have that. And we saw that happen with COVID, and we see that happen every time a large healthcare system gets ransomed. Their ability to respond to that and have the depth of capacity to still take care of patients at a high level just goes out the window. And so because of those constraints, how expensive, how many other draws on healthcare there are, the investment in cybersecurity in healthcare has been exceptionally variable. These are the cyber haves and the cyber have nots, right? If you're a very well resourced private hospital, you have an impressive security team and you deploy the latest mitigations, not necessarily those the best, but you have a much more defensible network than a small community hospital or a rural hospital, a critical access hospital, where in those institutions, those hospitals don't have two nickels to rub together, let alone invest in reasonable architecture. So what do you have? You still have hospitals running Windows 7. You still have some of their server infrastructure on Server 2K, and they just don't have the ability or resources to invest in cybersecurity. That, coupled with the general lack of cybersecurity talent and how expensive it is to recruit those individuals to a healthcare institution and have them stay and have them live in a rural area, for example, and help that hospital better defend their network, it's a really tall order. And all these things come together in a nexus to make it particularly difficult for healthcare to be able to defend itself.
Yeah, and it looks like Lisa, please. It looked like you had some thoughts there.
Well, I was just going to say, I agree with, it is a complex problem. And also, the knowledge, skills, and abilities on the front line of healthcare are healthcare focused. They're medical focused, not IT or technology focused. They use the technology in their role and in their job. And to your point, we call it target rich and cyber poor, right? So they're a rich target for nefarious operators and people who want to wreak havoc. But to your point about the have-nots, most healthcare, like manufacturing, like energy, like water and wastewater, they're all resource constrained. They can't go to the market and just raise prices for their products and services that they deliver. They're largely regulated. There's other rules that have to be followed. So I will also say, we're going to get to some solutions, I think soon. We're moving that way. But I would also say that, there's been there needs to be a shift. Maybe there hasn't been, but we've been focused on a lot of sort of compliance obligations, which are important rather than risk-based focus. And I think when we get to some of the solutions, one of the things that we can think about is how do we plan, do, check, act, and prioritize on those processes that, that Stephanie mentioned, those 60 pages. They're not easy, but how do we prioritize them in a way that is meaningful to our organization? So I'll stop there and let you keep going, because there's a lot of good stuff we still have to get to about how to help people solve some of these problems. we know it's bad.
We're going there next. So just one quick thing, for the purposes of the Q&A, which we will get to after this last little segment, please use the Zoom Q&A function. I see some of you are already doing that, but if you have specific questions, please do type those in and we'll get to those when we get to the Q&A. But yes, let's start talking solutions, because it's not enough to admire the problem. No one wants to sit around and admire the problem. So let's solve the problem to the extent that we can. So Lisa, I don't know, maybe you want to go ahead and kick us off. What are some of the things that that CISA or that you're seeing as ways that we can really start to address this issue?
Sure. And this is part of, so some people will say, and I think we even said it in this, what does COVID-19 have to do with cybersecurity? So to Stephanie's point, and to the rest of us, this notion of digital, right? This notion of cyber physical, this notion of how we use bits and bytes to control these technology resources. I think over the last year, we've developed some really good tools, techniques, and methods. Let me say it that way. So at CISA, all of you have made the point that there are still many have-nots in healthcare. So we've published some things called bad practices that are known bad practices. And the reason for the publication is that in my work with a lot of healthcare and other resource-constrained organizations, many of the CISOs, and many of them don't have CISOs, they just have IT, or they have an outsourced IT function, right? And someone in the chat asked about concentration risk, and that is real. If you're using the same IT provider or the same set of IT providers in a region, there's some concentration risk there. And as we think about, what we can do and what we should be doing, back to basics can actually help. I know that sounds trite, and it's not, I'm in this fight every single day, but I will tell you that many of the ransomware research reports, many of the things that are out there right now will tell you that we don't manage privileged access very well. And so let's say that you're, 80% of some of the studies will say that most organizations, 80% of them don't have privileged access management tools because they're expensive, or they might not be in your budget for this year. While that's true, okay, there should be some compensating controls. If you're not able to do the things that, maybe some of the haves can do, how do you then make sure you check the windows, check the locks, check the door? You do a plan, do, check, act, a programmatic review of what you can do, because there's a lot of things that you can do. And I think we get overwhelmed sometimes. As a practitioner, I know I get overwhelmed by the signal to noise, right? There's a lot of noise. There's a lot of shiny squirrels. There's a lot of competing priorities. There's a lot of things that are going on. But if you just cut that out for just a minute and say, okay, how am I going to, I say get back to basics. How am I going to make sure that, okay, so I can't afford privileged access management. Okay, how am I making sure that I'm planning, doing, checking, and acting the people who do have privileged access, the people who are responsible for that? How do I make sure that we're checking the boxes and checking the actions of these to ensure that the compensating controls are there, even when you can't buy a technology solution? So I'll offer up that one first, and then I'll hear from my colleagues, and then I'll offer up some before we leave today, and I'll put some links in the chat window while we're talking.
Perfect. Well, why don't we go back to Stephanie? Stephanie, what would you add on?
I'm trying to think. I'm trying not to just re-say the same thing me and everyone is saying. So I'm trying to think, one of the big things I'm going to switch to advice, right? What's the advice that I always try to, and I'll be more tactical, I guess, with advice. And I think one of the most fundamental pieces that is helpful, whether it's a hospital or any ecosystem, is asset management. And I realize that doesn't actually sound very sexy, but at the end of the day, the number of entities and hospitals included that don't actually know what all is on their network is a little scary. I mentioned that 15 to 20% of some of the hospitals that I worked with, they found that medical devices represented that portion of their endpoint. Those were actually hospitals with very mature asset management. A lot of hospitals that I worked with could not answer that question. And so that to me is kind of one of those foundational, just table stakes, right? Figuring out what you have. And the other thing I would say to put a lot of effort into is how are you going to prioritize? This is another piece that I see hospitals struggle with is you can't boil the ocean. There's so many things to do with cybersecurity. And even once you get that asset inventory, like I mentioned before, you probably have thousands of medical devices, potentially thousands of vendors that you're trying to deal with. The risk of every medical device is not created equally. So coming up with methodologies for how are you going to actually prioritize and really hit the ones that matter, right? Sometimes it's about the device itself, right? The device's operating system, the clinical function that performs, but sometimes it's also about where is it on the network? Is it something that actually has to talk to the EHR? Does it have to talk to a cloud, or can I actually lock this behind rules that say, you can't go external? So building that prioritization equation for how you decide what is the highest risk and prioritize what you're going to go after first is so immensely underappreciated, to make sure you're not spending security resources in the wrong area, right? Christian and Lisa both hit on the fact that it's really hard and expensive to find security people. So when you do have them, make sure you're using them in the biggest impact area. And the third piece I'd hit on is build those relationships with those key medical device manufacturers. Once you decide and you figure out, well, what are the medical devices that are most critical and highest risk to my system? And highest risk doesn't necessarily mean that device was built poorly. It just means it either has a really critical clinical function, or it has to talk to the cloud and talk to EHR. Build those relationships with that medical device manufacturer so that you really do understand, how do updates come, what's the cadence that they come, how do I apply them, and make sure you have that open dialogue. Most of the medical device manufacturers I work with actually really want to do a good job. They do. There's outliers, but for the most part, most of them really want to do a good job. So explain to them back, right? If your thing had done this, or if the button had been here, or if the update had applied itself, that would have been helpful to me. They want to hear that, because that's how they make their products easier for you to use, is from hearing how it performed in your network and what would have been easier for them to maintain from a security perspective. So build those relationships and make sure you're actually pushing user needs back to them. They want to hear them. So those are my 3 tidbits.
Perfect. Well, Christian, do you wanna finish us off on recommended what we can do about it, and then we'll go into Q&A?
That sounds great. So I really have 2 main categories of recommendations. The first is going to be with data. The specific ask is that in institutions like the National Science Foundation or the National Institutes of Health, that those organizations fund research into this. We can't make informed decisions about securing patient workflows without data, right? So if all we're doing is working off anecdotes, like I've mentioned, or our theoretical things, we're going to miss the mark. So until we have that type of rigorous data, we're not going to be able to, as Stephanie mentioned, go over the biggest areas of potential risk to patient care. So until we actually do the research and incentivize organizations to give us that data and to study it and to not be ashamed of it, we're going to be at a little bit of a loss for a while. Also, that type of data can help catalyze the type of motivations and needs, motivations for these organizations to make change, right? I've been really sick and tired of the last 10 or 15 years of people saying, show me someone who died from a ransomware attack. I want a name and I want a story before I'll act. And what I believe really in my heart as a clinician is that there are patients harmed by ransomware attacks all the time, but we lack the sophistication and the systems to detect that harm and then to report it. It's not in any hospital system's legal best interest to report these things. And there's no external reporting requirement outside of the national, outside of the regional public health authorities. So what does that mean? We need something like a national cyber health registry, a place where if you get hit with ransomware and a patient has an adverse outcome because of it, you are required to report that to a centralized database that can then be used to fund, to do research and come up with solutions to fix these types of things, akin to something like the evidence-based medicine revolution of the late 1990s. So that's what we need. The first one is we need data, and we need to have structures in place to rigorously study this so that we can come up with good solutions that are evidence-based. The second is going to be resources. We've talked at length here about the cyber haves and cyber have-nots and how hard that problem is. In my opinion, the only way we're going to solve that is not to plead with hospitals that have no money to carve out more money. Right? The solution, that's just not going to be feasible. If your choice as a critical access hospital should not be, should I hire another doctor, a family medicine doctor I desperately need to take care of all these diabetic patients, or should I buy multi-factor authentication this year? That should not be the choice that we have. Instead, we should do something, and I talked about it earlier, we had this high-tech act that gave money to healthcare organizations to help them transition from paper records to electronic records, right? There was a subsidized national funding approach to that did a great job. Now there's not a lot of hospitals that are still on paper records. A vast majority of them are on electronic records. That actually worked. We need something like that for healthcare cybersecurity, wherein we can say, if you meet certain requirements and you make certain investments, you can get additional reimbursement for every CMS patient that you see. Something very much similar to the High-Tech Act. And then we need to say, if at some point you aren't doing these things or you're not investing the money that we are earmarking for that, then you will be penalized with decreased reimbursements moving forward, and allow a ramped up approach to that, wherein we can transform the entirety of the healthcare sector's cybersecurity preparedness and internal resources over 5 years, just as it requires some money. I think that would pull pretty well nationally, and would hopefully, even in this hyper-partisan environment, be a swallowable thing for Congress to say we need to secure the healthcare infrastructure. That in and of itself, at the tail end of COVID, I hope is an argument that hits, and one I would hope that we could motivate our lawmakers to do. And thank you for that opportunity to say that.
Sure. Well, let's go ahead and get into the QA because we have about 12 minutes
Before
left.
we do that, Jessica,
Yes.
Can I put you on the spot and say,
Sure.
Can you talk about what FDA is doing? I think it'd be interesting for people to hear what
Sure.
FDA is doing.
Yeah. Absolutely. So I, of course, think FDA is fantastic and we're doing great. And I am not biased at all. But, FDA is trying to do a lot where we're looking at this both internally and externally. So internally, we are very cognizant of the fact that, like Stephanie, I think you were the one who said cybersecurity is such a moving target, that even our own recommendations to industry, our own way of viewing cybersecurity, we have to be constantly iterating on that in order to keep up with cybersecurity threats. So we're working on updating our pre-market guidance. We're working on constantly improving the way that we respond to cybersecurity incidents and vulnerabilities in the sector. We also spend a lot of time working with external partners. Stephanie gets this a lot in her various iterations of things where, we're reaching out, we're working on task groups, looking at things like legacy devices, or how do we communicate better on vulnerabilities? Because trying to talk to patients about cybersecurity vulnerabilities is really, really important and really difficult. And I feel not bad at all in saying that everybody is terrible at it. So there is a dedicated effort within the healthcare sector right now to figure out how do we communicate better with patients so that when we talk about cybersecurity, it doesn't do like that Charlie Brown adults like thing where like they're not absorbing any of the information, but we're telling them what they need to know in a way that they can know it. And then I think the last thing I'd point out is we're working also internationally with our international partners on these kinds of things. So everywhere that we can sort of say, internally, we're gonna keep working on it. Externally, we're gonna partner. And then internationally, we're gonna try and make sure we're all singing from the same sheet, so to speak. We're trying to hit on all these things as often as we can, which is one of the reasons why my hair is starting to gray. But in any case, let's jump into Q&A.
While
Yes.
you're queuing up the questions, can I add one more thing, which is, one of the things we found when we stood up the task force is that a lot of people don't know who CISA is. So we've been traditionally providing services to the .gov domain. When we started calling, sort of the vaccine suppliers, they were like, who are you? Who are you? So let me just say this, that to Christian's point, there are free resources. There are resources available. If you are a have-not and you do need help, part of CISA's mission is, so I'm asking you all to be open to soliciting and receiving services from the government, because we are, in the fight with you. So.
Great. Well, Lisa, I'm actually going to start with you because we've got a couple of questions that I think CISA is pretty well poised to answer. So one was the concentration risk that you had mentioned earlier. How should we look at concentration risk and start identifying critical third-party dependencies? But in that same vein, I think there was another question about how do we address upstream dependencies? So power, water, telecommunications, which are part of, I think, the whole, if we want to call it, supply chain of healthcare. So from CIS's perspective and all of that, can you talk a little bit about those two things?
Sure, and I won't go into deep depth, but the agency does have a project that's going on called National Critical Functions, and National Critical Functions are the dependencies that underpin our entire economic, our healthcare security and everything else, critical infrastructure. So there is a project to both decompose and understand dependencies within and between the sectors of the national critical functions in our country. So that's an ongoing project. And I think a lot of the products and services that CISA offers to organizations to help them are because we see that it's not just there's not just one thing that could break. Once you get below sort of power, water, communications, healthcare, and public safety, all of those are so intertwined that they need to be looked at sort of holistically. And I think that that's what the agency is trying to do now. The concentration risk is part of that, basically understanding where, from a critical infrastructure perspective, does the government need to take a look so that we can help where help is warranted and needed.
Perfect. Well, Christian and or Stephanie, maybe we can start with Christian, and then Stephanie, I'd be interested in your take more from the security angle. We had one question about whether or not hygiene, everybody likes to talk about cybersecurity hygiene. Is that the right framing, or our questioner is asking if that's limiting our thinking? So what do you guys think?
That's a great question. I actually kind of like the term. I haven't really rigorously thought about it, but I like the term of cyber hygiene for clinicians. Jessica, you mentioned how hard it is to have doctors articulate the cybersecurity risks of connected and vulnerable medical devices to their patients, right? It's just not in their purview of clinicians, doctors, nurses, other technicians, but they understand the concept of hygiene. And when they don't practice good hygiene, bad things happen. And when they don't wash their hands, their patients get infections. If they aren't practicing good cyber hygiene from a user perspective, and they click on all those phishing links or whatever it would be, that is going to result in something bad. So it's able to hijack the language of microbiology and pathophysiology in the healthcare space to immediately connect with something that they care about, which is the health of their patients. If we start talking about things like phishing and denial of service attacks and multi-factor authentication, if you start going down that techno jargon aspect, you're going to lose a lot of very important stakeholders in the conversation. So in that regard, I think cyber hygiene, when talking about people who are generally not practitioners in the security space, is a good and useful term. Now, that might not hold for the rest of it. And so I can't really remark on anything outside of that, but I've had success in communicating patient safety and care quality concerns from cyber attacks to clinicians using that term cyber hygiene. But maybe in the future, the term might change. In the meantime, we have a very big problem, which is just even the basics of communicating why clinicians should care about this. They don't care. They have so many more emails, so many more patients to see. They see this as an IT issue outside of their wheelhouse, and they don't have to be involved in it, although their direct actions can compromise a network that gets infected with ransomware. So we need to be moving more in that direction where cybersecurity is a regular conversation. Hygiene may be a good way to do that, and I've had success with that in the past.
It's interesting because I've never actually talked to someone else about like what cyber hygiene means to them. So it's interesting to actually hear Christian's, because it's actually very different from my interpretation, which is actually maybe one of the reasons that it's not a good term. So I don't have a clinician's background. And whenever I've heard or used the term cyber hygiene, to me, cyber hygiene always meant kind of the just base expectations, right? The table stakes expectations of cybersecurity. Because to me, hygiene means something like, I just expect every adult to have washed their hands, right? When I used to go to conferences and shake people's hands, right? I just expected that people would follow basic hygiene, right? That if I shook their hand, that was not a super gross thing to do. And so when I would talk about cyber hygiene, I was always thinking of it as like, this is just the table stakes expectations for cybersecurity. And cybersecurity goes way beyond that. So cyber hygiene to me very much meant like the base level of expectations that people should be meeting. And there's definitely layers above that. But if you could just get everyone to kind of do the baseline, that's where you'd be at. So it's kind of interesting that I actually I've always thought of it very much as like the baseline expectations and kind of like the minimum that everyone should be doing, just like I expect everyone to at least have a minimum level of hygiene.
But that's a good point, because I worked a lot in safety instead, before I came to this job, and we use the language of safety to help describe vulnerabilities as defects, right? because from an engineering perspective, they want to hear about the defects that they can fix as opposed to vulnerabilities. So using the language might just be a lever. But it's funny you say that, because yeah, I see hygiene is exactly the same as you described it. But I like the idea of pulling the language thread, because I think that could really make a difference, right? Meeting people where they are, right? And using the language to demonstrate that.
We have only a couple of minutes left. So I think we can answer one of these questions maybe fast and then combine the other two. So Stephanie, I don't know if you feel, we have a question about if there are recommended tools or audit controls that can help streamline some of the solutions that are being recommended. I don't know if you have anything to offer on that.
Yeah, unfortunately, I have not found one out there that I super love. I feel like it's more important to find something that gels with your higher level security processes. So I saw they mentioned things like the CIS and their security controls and benchmarks. Some people are really like NIST shops. And to be able to speak the consistent language between what you're doing from a clinical security perspective and what you're doing from a corporate security perspective is so immensely important. I would honestly say you should just align with what the greater organization is doing, even if it's maybe not that perfect fit, because at the end of the day, what you want to do is be viewed from a clinical security perspective, right? You want to be viewed at the same level as things like traditional endpoints. I have the privilege of sitting on some cybersecurity boards of hospitals, and I can tell you, bringing the medical device security voice to those board level meetings, it was so immensely critical that it spoke the same language that everyone was used to doing, that medical device just dropped in as basically, it just worked in the charts that were already there, right? They happen to be a NIST shop. And so, you know what? It fell into the NIST security controls catalog, and they mapped it to the same controls that they were mapping on the critical infrastructure. So I haven't found one that I said is worth the divergence. It's actually better to just speak the same language as the rest of your institute.
Great idea.
All right. Well, I think we are right at time. And so we can go ahead and wrap. I don't think Philip is going to come back on, so I am now responsible for closing us out. So thank you, all so much for attending, those of you who have stuck around through the end. Thank you to all of our panelists for, I think, a really robust, really fun discussion today. And hopefully we will all have a very quiet, let's all say, cross our fingers for a very quiet rest of our Cybersecurity Awareness Month, since we had a very busy beginning to it. But again, thank you all, and we will hopefully see you all again in the future.
And thank you so much, Jessica, for moderating and pitching this really awesome discussion today. And for all you attendees for taking the time. And if you guys are interested in these conversations and more, please do check out securityandtechnology.org, where we'll have more events to come later this Cybersecurity Awareness Month and beyond. And follow our social media for new events, new publications, and more great connections with the panelists like you've heard from today. Really appreciate it. Everyone have a great day. Stay safe.